Well, kia ora tātou, everybody. Bruce Arrell's my name. I'm the director of the Goodfellow Unit, and it's my pleasure to introduce Dr. James Yap, who's the medical director at Totara Hospice, which is our local hospice near our clinic. He's been a consultant there for the last 9 years, working in the community and inpatient and hospital cover roles. He's talking tonight about palliative care for the non-cancer patient. And I was just telling him about my regret on having a patient who I'd known for more than 30 years, who I got to know when I first started working in Manurewa. She was in her late 60s. She died in her 90s. And she didn't have cancer, but she was getting increasingly frail. And I knew the end was coming. And she ended up dying in Middlemore Hospital in an acute ward. And I thought that must have been a very lonely death for her. And I have vowed ever since to do better. The issue of the difficulty, of course, and James will talk about that, is what's the trajectory of somebody who doesn't have cancer? I think that's particularly difficult. So James, over to you and your expertise. Welcome.
Thank you, Bruce, and thank you for the opportunity to talk at this webinar. So as Bruce said, I've been working at Totara Hospice for the past 9 years. We cover South and Southeast Auckland. We've been in the area for about 39 years and still going strong. So before we get started, I just want to start your thinking, start to ground you here. So I want you to think about the letter Y. And I'm just about to share screen and bring up my slides. So think about why. Why are you here tonight? It's Tuesday night, you've had a long day at work already, but you're coming here to listen to a lecture about palliative care for the non-cancer patient. Why are you here? Why are you here on this world? Just take 10 seconds to think about that. Why are you a doctor? Who are the people you want to help? Why am I here? Well, I think my life mission is to try to make the world a better place for dying people. That's why I'm here. So just take 5 seconds to think about why you're here, and then we'll get started. Thanks. So the outline for tonight is, when is my patient palliative? As Bruce said, this can be really hard to tell, especially with people with non-malignant conditions. When should I refer? Who should I refer to? We'll talk about some helpful tools, and then there'll be lots of time at the end for discussion. I'm trying to keep the slide part of this talk fairly short. So palliative care from diagnosis to death. I'm just going to show this video quickly, and it's an excellent one narrated by Dr. Scott Murray, Professor of Primary Palliative Care at the University of Edinburgh, retired back in 2020. He was part of the Primary Palliative Care Research Group, so I'll just bring that up and we'll just play it because what he has to say is pretty pertinent even to our situation. Just while you're watching it, think about how it tracks to the New Zealand context and how Te Whara Tapawha and its 4 domains could fit in quite nicely with what his video shows. So I'm just going to play the video now.
So this talks about the rationale for early palliative care. It's that there are 3 typical illness trajectories, each with 4 dimensions towards the end of life. Early palliative care may prolong as well as improve life's quality by promoting realistic medicine, and many people can benefit from early palliative care, meeting the likely needs of people with advanced illnesses. So what does early palliative care look like for people with different illness trajectories? Well, there are 3 main typical trajectories of physical decline at the end of life. The rapid decline, typically of cancer, intermittent decline, typically organ failure, and the gradual one, typically frailty or dementia. But dying, of course, is a 4-dimensional experience, at least: physical, psychological, social, and spiritual or existential. So let's look at the rapid trajectory first, typically cancer. Well, the physical decline we've seen coming towards the end quite rapidly, quite often. And the social decline tends to run in parallel, we'll find through many research interviews. However, the psychological distress and anxiety and worry tend to be worse at 4 times around diagnosis, after treatment, recurrence, and around death, similar times that existential issues may be expected. So the message for the rapid trajectory: people with cancer need an early palliative approach, even when they may be physically well. Other dimensions may actually be causing the acute distress anxiety. So simply acknowledging anxiety from the beginning is really appreciated by people. So in the intermittent trajectory of organ failure, what's happening there? Well, the physical trajectory has these dips. Physical decline is episodic, usually followed by partial recovery. Sudden death may appear at one of the dips or between. And social decline and psychological decline often runs in parallel with the physical decline. Spiritual decline is harder to define exactly what's happening there. It can be moderated by various aspects. So the message for people on the intermittent trajectory: early interventions that address psychological and social issues may be more effective than actually addressing just the physical. And similarly, preventing things, it's good to consider these other trajectories. The gradual decline trajectory, let's look at that one now, typically frailty. So here we go, the gradual physical decline over many years, many months or years. And looking at the social decline, and the psychological decline, and even the existential distress, these often dip, in fact, before the end. Sometimes these dimensions can decline and can be seen that. Maybe someone has a problem before. So the message for that is support people in these other dimensions, not just the physical, to promote resilience, to prevent anxieties. Address the racist fears, which may be loss of dependence, dementia, or being a burden, rather than actually dying, of course. So the plan ahead for helping people at the end of life. For early palliative care, identify people early. Look at the different dimensions of need and maybe talk to them about what might happen. Discuss the trajectories with the people in their care and map them out, letting them understand what's happening, and plan integrated care, ongoing with disease management, and communicate the plans everywhere. Thank you.
That's terrific, James.
So there's a nice little video, and the YouTube link is just here, and a copy of these slides will be made available through a PDF, and then you'll be able to click on the links and access the videos. But I found this video very clear and succinct, and we are working on a New Zealand modified version, which will reflect things in our context more, but it does a pretty good job. So next, I want people to know about the big picture. This is the big picture in terms of where palliative care can be involved. And as you can see, we're happy to be involved with folks who are still having curative care. So anywhere from diagnosis onwards, and people may still be having lots of active disease-directed treatment. There may come a point when this becomes less important. And as death approaches, we enter the end-of-life care phase, and then afterwards the bereavement care phase. So you've got to stop to ask yourself with each patient you've got, what is the big picture? Where is Wally on this little continuum? So I'm going to talk about a case in which things didn't go so well for the patient and her family, and for those involved. So Mrs. L, she was a 65-year-old retired midwife. She had only just retired at the time that we got involved. She'd been working a few hours a week as a midwife, even though she'd been getting more and more unwell. She was a proud mother and grandmother. Her son and grandchild lived in central North Island, so they were fairly far away, and it took quite a trip to get down to see them, or for them to come up and see her. She lived close to the beach, but had recently purchased a new house closer to the city. She had a very strong Christian faith. Past medical history of note was Sjogren's syndrome, and she had developed interstitial lung disease starting 14 years ago. She had become quite steroid dependent, and her 6-minute walk test from just 2 years ago was only 172 meters, so really quite impaired. BMI was 32. This was due to steroids as well. She had steroid-related osteoporosis and had sustained a number of thoracic vertebral compression fractures, which were really, really painful. And here's just a little reminder on the little graphic of what Sjogren's syndrome can do to a person, so it can affect many systems and cause many symptoms, and it certainly caused a lot of comorbidity in this lady. So T-minus 6 months, we saw that respiratory issues were noted to have worsened. She started on long-term oxygen therapy, recommended to have 16 hours a day, but to start with, she found this really difficult. There was a bit of a stigma attached with it. She was still trying to work as a midwife, as I said. The aim was to maintain her SATs at above 90%, but her functional ability was starting to worsen. She was limited by shortness of breath on minimal exertion. As I said, still able to work as a midwife, but had to cut down to just a few hours per week and had to cut down a number of cases that she could actually take on. T-minus 3 months, things were getting worse. She could no longer work. She was starting to have recurrent chest infections, some of which led to hospital admissions. And in one particular hospital admission, high-resolution CT scan revealed significant progression in her interstitial lung disease. Lungs transplant was discussed at this time by the ward team, although they thought that she was an unlikely candidate given her comorbidities. They sent the referral through anyway. So T-minus 2 months, referral was made to the hospice by her GP. Her GP was a city-based GP, and this lady was actually living close to the beach, so she was quite a physical geographical distance away from her GP, and she ended up changing GPs as things got worse. Hospice was involved with symptom control of her breathlessness and related anxiety. Things were steadily getting worse. But as I said, she had a very strong Christian faith. She was convinced, she believed that she would recover to her previous level of function. The prognostic mismatch that the hospital staff identified was gently addressed with the patient. We were trying not to step on too many people's toes, but we wanted to try and prepare her for what we thought might be happening, which was a situation of deterioration. T-minus 1 month, she had another chest infection, and this required hospital admission again, IV antibiotics, high-dose steroids. After this admission, she'll start on some morphine elixir and Meslon for shortness of breath, which did help. T-minus 2 weeks, she was followed up in a respiratory clinic by a consultant who had seen her for many, many years. It was noted that her O2 sats were 80% on 5 litres, worse than 1 month ago when she had just been in hospital. She had been declined by the transplant assessment clinic, given her disease severity and ongoing deterioration. Mrs. L and Mr. L asked the specialist how long she had left to live, and from what was said, it sounded as if 18 months was a figure that was bandied around, unless severe deteriorations from infections were to occur. And just got to keep in mind, at this stage, she had already had 2 severe chest infections resulting in hospitalisation and IV therapy, as well as other therapies. Mrs. L was still aiming to get back to her previous high level of function. She really did love her job. She really did want to get back to work as much as she could. As I said, recently bought a house and they were due to move in within the next month. And specialists had signed her in for follow-up in 3 months' time. T-minus 1 week, she had another chest infection, initially treated with oral antibiotics over the course of a weekend with no improvement. By Monday, she had become acutely unwell with delirium, dehydration, and O2 saturations of 52% on air. Her new GP had seen her on a home visit, had talked about what she wanted. Hospice IPU admission had been offered, but the patient and her husband and family just were not in that sort of headspace, wanted to go to hospital to try to reverse the situation. Rushed into hospital for treatment, and Mr. and Mrs. L wanted full resuscitation. T-minus 2 days, ICU registrar was called to review Mrs. L, where she was really, really unwell. She was deemed not for ICU admission given all of her various comorbidities. CPR was not recommended. And this was backed up by the respiratory physician, who also thought that non-invasive positive pressure ventilation was not indicated either, thought that she was at the very end stage of her life. Concern was raised about this, but this came as a bit of a shock to patient and family. If you remember, 2 weeks ago in respiratory clinic, under the consultant that they'd been under for a long time, they talked about the possibility of 18 months of life. So a very difficult conversation was had between the duty ward respiratory physician and the L family, and a clinical decision was made that Mrs. L was not to be resuscitated if she was to require this. And 2 days later, T-0, she deteriorated even more rapidly, even more so, and she actually died, and CPR was not performed as had been explained. Mr. L and his son, who had only just arrived in time to see his mother before she died, were both very, very upset and asked for coronial review. So this was requested by the hospital team, but the coroner declined to take the case any further as he could not find any wrongdoing with his viewpoint. So the case came to my attention 2 months later because Mr. L was still very, very upset. He was bereft, devastated. Came in to discuss the issues with myself and one of our counsellors at the hospice. We explained the situation to him, that Mrs. L had been deteriorating rapidly and had limited time left. He said, but the consultant had told me she had 18 months left, and if we had known that she had such a short time left, we would have made different choices. They had missed opportunities. They had a new house that possibly they could have moved into a bit earlier. They might have chosen to spend more time with family instead of trying to, they both were still working their jobs, and they might have tried to spend more time together as a family, including with her son and grandson and daughter-in-law, and talked about whether or not he wanted to take it any further, like the HDC and that sort of stuff, but he wasn't keen on that. But he wanted me, he made me promise that I would use this case to teach others, and hence why I'm presenting it tonight and at other places, because he was very keen that we use Mrs. L's case to try and prevent what had happened to her and her family from happening to others. So could we have done better with this case? Well, yes is the obvious answer. And this is a little graphic that I came up with a few years ago to sort of look at long-term conditions such as COPD, interstitial lung disease, organ failures of various types, including congestive heart failure. So we've got a long-term condition as the big oval, and then there's a time for primary palliative care to be involved, and that could possibly be identified with something called a SPICT tool, which I'll talk about in more detail in the next minutes. And then there's also a time for the possibility of specialist palliative care involvement. So if only there were some helpful objective tools. Well, luckily there are. So the first one is the SPICT tool, so supportive and palliative care indicators tool. I might just bring that up on the website so you can have a clearer picture. So SPICT tool. So this is really quite a useful tool developed by the University of Edinburgh. Sound familiar? They're doing some really good work there. So if you look at your patients, and this is if you look at your list of patients in your own GP practice or in your residential care facility practice, you can try to see who would fit the following criteria. If there's any general indicators of poor deteriorating health, for example, unplanned hospital admissions, decreasing performance status, becoming more dependent on care, the person's carer needing more help and support, the patient having more significant weight loss over the last few months, persistent symptoms despite optimal treatment, or the person is asking for palliative care. Possibly they may need to be considered a palliative care patient. They may possibly only have 6 to 12 months left to live. And so a palliative care approach may become more appropriate. And then there's specific clinical indicators for various disease processes, including respiratory disease. So if you've got severe chronic lung disease, for example, with breathlessness at rest or minimum effort between exacerbations, persistent hypoxia requiring long-term oxygen therapy, or if you need ventilation, or if ventilation is contraindicated because you're too unwell. So these may all be triggers to consider your patient as a palliative care patient. And then if that's the case, you might have different choices as to what to do in terms of their healthcare. Another useful tool that I'll go over is known as the Australian Modified Karnofsky Performance Status, the AKPS. So this is a functional status tool, and it's really helpful, and palliative care practitioners have been using it all over the world the last few years, and we're now getting it out into communities, getting into hospitals, getting into residential care facilities. And it's quite simple. Once you learn it, you can actually get a score done in, say, 1 or 2 minutes. So it's all about activity levels. And so, for example, all of us at the moment are normal. We've got no complaints, no evidence of disease. We're 100%. Mrs. L, 6 months before she died, possibly still was able to do some normal activities with effort, but there were some signs or symptoms of disease, and as she got more unwell, she went further down the line. So right down the bottom is comatose and then dead. So that's another useful tool. And as I said, links for these tools will all be available on this little PDF that will be given to you. Phase of illness is the next thing, and I'll just bring up the slideshow again to show you what that looks like. And switch play there. Okay, so that's again AKPS, and this is phase of illness. So there's 5 different phases, and so patient can be stable. Problems are things are not changing. Their symptoms have not changed majorly, not needing much in the way of change of management. Unstable is when a change in plan or treatments is required because the patient's condition is changing. Their breathlessness, for example, is getting worse, or their functional ability is getting worse. They're needing extra help, so they're classified as unstable. Deteriorating is when a person's overall functional status is declining really quite rapidly and new problems may pop up. Dying phase is when death is likely within days. And of course, deceased is when the patient has died, and this is when palliative care's bereavement support role is important. So if only this could all be packaged together, and thankfully in at least Auckland, there is a way of doing this. And so I'm just going to take you through to the Poi website. So Poi Community of Care. So this is a Auckland-wide initiative, one of the Hospice Innovation Fund initiatives from a few years ago. And here's the website. You can see the website, and it's got lots of useful information, including links to the resources that I've just talked about, phase of illness, SPICT tool, AKPS scoring, also stuff about ACP considerations, also into RI, and something called the PPA, which I'll talk about in a minute. There's a whole bunch of resources, including a good link to a previous Goodfellow Unit talk. There's the link to Te Ara Whakapiri, which is very appropriate for people who are at the very, very end of life, last days of life. Previously known internationally as the Liverpool Care Pathway, but this is the latest New Zealand version. It's got some really handy symptom control guidelines. If you can cover the 5 symptoms at the end of life, which are pain, breathlessness, nausea, agitation, respiratory secretions, you'll be doing pretty well with end-of-life care. So those are the 5 main symptoms you need to cover. And also a link to the Palliative Care Handbook. And I'll just bring those websites up for you quickly. So Te Ara Whakapiri, the Unifying Path, Principles and Guidance for Last Days of Life. So lots of good material here, and just concentrate on the recognising and dying person flowchart, and also symptom management guidelines. These are really good. Palliative Care Handbook can be downloaded from this website. So again, all these links will be available to you in the PDF. So what's this Poi stuff all about? Okay, well, I'll tell you in a minute. If Poi had been involved, we might have been able to spot a few things. So what I've highlighted in green is SPICT criteria that could have been fulfilled. So right at T-minus 6 months, respiratory issues had worsened despite optimal treatment, needing oxygen, functional ability worsened. These could have highlighted that Mrs. L was a palliative care patient, and this could have sponsored a conversation, a preparatory conversation, as in things are changing, things may change further, time may be becoming short, you may possibly only have 6 months left to live. This would be backed up by the AKPS of which had gone from 80% down to 70%, been able to do normal work activities down to not being able to do as much, phase shifting from stable to unstable. Again, looking at the big picture in the lower left hand corner, where's Wally? Wally was heading towards the right hand side was what was happening. T-3 months, again, this could have been another opportunity to intervene with, if, according to the SPICT tool, she couldn't work anymore. She had recurrent chest infections leading to unplanned hospital admissions, significant progression of disease on CT scan. Again, this was reflected in the AKPS score at the time would have been 50%. The phase would have become unstable. So as you can see, a drop in the AKPS could mean a major deterioration in patient's condition. Are they going to recover again? Possibly yes, with non-malignant conditions. People can recover a bit, but they never get back to their baseline. They might go from AKPS of 70% down to 50%, but they might get back up to 60% or 65%, but they're never quite as good as they were before they became unwell. So looking at the big picture again, where is Wally on the timeline? He's walking closer towards the right-hand side. So that's what you've got to keep in mind. Time may be becoming shorter. So T-2 months, symptoms were not controlled also well. Anxiety was getting worse. So a prognostic mismatch was talked about, but and gently addressed. Maybe it was too gently addressed. Easy to say in retrospect. AKPS at the time was about 40%. Phase again was unstable. Wally was walking again towards the right-hand side of the diagram. T-1 month, again another chest infection. Again, AKPS was starting to drop 30%. Not able to do as much, spending most of the time in bed would have been the situation. Phase had become deteriorating. And this is when in specialist palliative care, we would start waving a bit of a red flag. 30% means that possibly the patient may only have weeks left to live. And so we would be getting the local GP apprised of the situation. Your patient may possibly be entering the last weeks of their life. You may need more intense input. Home visits, syringe drivers may be required. Same with the residential care facilities as well. So Wally is steadily heading towards the right-hand side, towards the end-of-life care part of the big picture. T-2 weeks, again, deteriorations had been noticed. Wally heading on and on towards the right-hand side of the picture. T-1 week, recurrence of chest infections, acutely unwell, delirium. I would have said that her AKPS had become 20%, needing to spend a lot of time in bed, most of the time in bed, heading into the actual dying phase. And you see Wally sort of starting to slip down or slide down. T-0, AKPS had become 10%, pretty much had become comatose in bed when she was in hospital. She was certainly in not just dying phase, but the active dying phase. AKPS was continued to drift down. She died. CPR was not performed. And again, she died before she could move into a new house. Mr. L and her son very upset. If they'd gotten previous warning, they might have been able to arrange for more time with her and her family together. But this unfortunately did not happen. So Poi, community of care in a nutshell. The gist of it is we wanting to create opportunities for better memories in the last 6 to 12 months of life. Just give me 1 second. So it's a culture change program aimed at earlier identification of palliative care patients. It's about trying to get the palliative care approach started earlier. Lots of research has been done, and in New Zealand has shown that up to two or 3 years ago, palliative care was only referred to in the last 3 weeks of people's lives, which made it very, very stressful for the patient, for their family and whānau, and also for the healthcare providers involved in each case. So we're wanting to identify palliative care patients earlier so that we can get the palliative care approach started earlier. And with Poi, there's a funded palliative pathway activation conversation. So the conversation part is a really important part. It's where you talk about what that patient may possibly only have 6 to 12 months left to live, and what is important to you at this stage. What do you need to sort out, including wills, EPOAs, people you want to see, people you want to get back together with. So this is funded in the Auckland region with $150 fee and plus GST through the PAC system. And as I said, trying to identify people prior to death, giving them more time to prepare. So it supplements or point towards the making of an advanced care plan. So it's not a replacement. So it doesn't replace a hospice referral either, but can guide primary palliative care, which may identify the need for hospice involvement if required. So why Poi? Why bother with Poi? What's in it for me? What's in it for me as a GP? Well, you may only be seeing 2 to 3 palliative care patients a year out of your 1,500 to 2,000 patients on your own books, so to speak. Palliative care, not a great earner financially. You may have to do home visits, but it's really, really good for goodwill generation, and the families really feel well looked after, and will thank you for that. Not every one of your patients will get COPD, congestive heart failure, dementia, but eventually every single one of your patients will die of something at some stage. So doing a Poi PPA or similar thing in other parts of New Zealand may help the actual individual patient and their family, but also could help the next patients that you find in the situation down the line. So if you've been through the process once with one of your patients, it'll make it easier for you to do so later on down the line, and it could help them really transition into a different way of thinking. So Poi might not be in your region or your district, but the Poi approach, the palliative care approach, could still be considered. So think about looking through your list of patients in GP land or in the aged residential care facility land and see who would qualify as palliative using the SPICT tool. And this could be repeated every 6 months, and list generated could become your palliative care patients of concern list. These are the people that you're a bit worried could possibly die within the next 6 months. And so you have an opportunity to intervene or to stop unnecessary interventions, some of which may be very invasive. So the aim of it all is to have better last months of life, better memories, or better opportunity to create memories, and hopefully less complaints. So what happens towards the end is an acceleration towards the finish line. So bodies can only take so much of these accumulation of physiological insults. This can be extremely rapid at times. And so the question in my mind as a specialist palliative care practitioner is, whenever I see patients, is my patient dying? What is the big picture? Where are they on the big picture? Falls can occur, and by falls I am referring to whare tapawha. Falls can be physical, can be emotional, spiritual, can also be whānau, the social situation not coping as well. So things start to fall down, homeostasis is lost, people start to lose their footing. So a simple prognostication rule of thumb is that if changes are occurring over months, possibly a person may have only months left to live. If it's only weeks, if the changes occurring over weeks, could be just weeks. And if it's days, hours, it could be hours. And sometimes we see these changes really, really rapidly. And in Mrs. L's case, I think this was what did happen. Things just kept on changing very, very quickly. So here's a bunch of links. As I said, the Poi program is available in Auckland only at the moment. Outside of Auckland, you can go to the HQSC website, which has got some really good material, which I'll bring up right now just to give you a quick look at. So HQSC, this is also the current home of the ACP, National ACP program, so you can find lots of good material on the ACP. But I've also got some great stuff about shared goals of care in the residential care facility settings. And this is one of the shared goals of care form. So it's like a mini PPA, like a mini Poi PPA form. It just goes through all these important things like, is there an advanced care plan, is there a guardian, EPOA, discussion that you have with the patient about understanding of the condition, how much information they want to know, share your understanding of the condition, and the most important part is what is important to the patient and their family at this time in their life. So you summarise and check for shared understanding. And so this is a nice little mini form, and this is residential care facility version. There's also a hospital care version, and it has at the back what to do in regards to CPR. And so it's quite clear cut, and it's really good form. So please check out the links yourself. And also on the HQSC website, there's some really good frailty care guides aimed at aged residential care, but could be really, really useful in GP land as well. Hard copies are available, but there's lots of good free downloadable stuff here. So defining and recognising frailty, acute deterioration, gradual deterioration, last days of life, lots of good stuff, delirium, dementia. So I'll leave you to look at that in your own time. And last but not least, here's another little palliative care website that myself and some Australian friends developed starting back in 2014. So this is our little online virtual community of practice, Palliaverse, palliaverse.com. So we're on the Twitter, on Facebook and all sorts of things. And this is where you can take part in the palliative care conversation. You'll find that I write occasional blog posts here on this site. And we've been talking about all sorts of things like COVID and other things. But back to the slideshow again, because we're just about to finish with the slides. So here's where I'm just going to open, or Bruce will open things up for discussion and questions. You've just had a hot, long bath in palliative care goodness, hopefully, and hopefully you're feeling really relaxed, just like this little monkey in Japan, had a relaxing dip in the pool. So please feel free to ask questions about palliative care or life in general, the meaning of the universe. And if anyone else anything comes up later on, please feel free to email me at jamesyap@hospice.co.nz. And as I said, a copy of the slides will be made available as a PDF, and hopefully you'll be able to click on these to access those websites that we've just talked about. But I'll hand over to Bruce.
Okay.
I'll stop sharing.
So James, got a few questions here. First one is, could Poi be rolled out at a national level? Is it just an Auckland thing at the moment?
It started off, as you see, I've just had a costume change. So this is the Community Care Specialist Hospices of Auckland. So it started off as a hospice innovation project, and it was aimed at regional Auckland. So money's from the Ministry of Health, and we have just done an evaluation of this. External evaluation has been done, and it looks quite promising. So there is potential that if the Ministry of Health likes what they see, they might want to consider rolling it out in other places, but it's certainly not the Poi Group's plan. We're happy to concentrate on Auckland in the first instance, but we've had lots of interest from other parts of the country, including Wellington and other places. And so, yeah, potentially it could do so in the future.
I presume the resources are still available, aren't they? People can go to the website. They don't need to.
Yeah, the resources are all freely available, and the mindset, I think, is one of the most useful resources there. And so I think if you're taking the Poi approach to palliative care for your patients in residential care facilities and GP practices, I think it would be a good thing. One of the things of the evaluation that we had recently was that people have started using Poi as a verb. Oh, has your patient been Poi'd yet? Because if they've been Poi'd, they'll probably have better end of life care outcomes, better for the patient, the whānau, and also for the staff, the caregivers looking after the patient as well. It's all about trying to make a stressful situation less stressful, trying to calm down, and also buying people the chance to have a better last 6 months of their life.
I picked up on your point about the goodwill your patients get from doing this work. You'll know Peter Wolford from New Lynn.
Yes.
And
yes,
he
definitely.
came and talked to us in the department. I'd never met him before. And he turned up and talked about, this is 25 years ago. He never charged patients for palliative care. He said he got it back in goodwill and building up his practice. And I think nowadays people can be charged for these things, but I remember being very taken. That was my first meeting of Peter, and I've always been a bit of a fan of him ever since.
Yes, me too, Bruce. Me too.
He's sort of he's got a bit of a following.
Yeah,
Okay, so questions here. For the PPA consult conversation, would you recommend any particular approach? Serious illness conversation guide. We do not have this funding in my DHB yet, but would love to learn more. Do you have any published outcome measures to support this project to help encourage funders? So this is Ciara, so she's obviously interested in
yes.
pushing the funding envelope.
Certainly, we have been capturing lots of data with Poi, and its results have been quite pleasing. As I said, we've just had external evaluators evaluate the whole program over the last, it's been running since November 2017, and the results so far are promising. Given that we've only had $2.3 million a year of funding, we've been able to produce some fairly good results, possibly decreased ED admissions for our patients and better outcomes for our patients. And so a lot of data is still being gathered and will be available soon. I don't have permission to share it tonight, but it will be available and certainly has been shared with the Ministry of Health. So hopefully someone will take notice.
It's always puzzled me that hospices have to raise a certain proportion of their own funds. I'm sure it must, well, it does give you some control, doesn't it?
It does give us some control, but given the COVID lockdowns and everything last year, ourselves at Tautra and all of our brother and sister hospices throughout the country, throughout the world have been having trouble because we haven't been able to fundraise. We haven't been able to gather huge numbers of people together to join us in our sunrise walks or join us in our ladies' lunches and the like. And so we have all, as with other charitable organisations, we've all taken a financial hit, but our work's important, so we've got to keep on going. And so we've had to make changes along the way, but we're committed to still being here for our people.
Here's a question. I think it's, I'll read it as it says. This is from Julia. Why do you think there is such an issue with the concept of palliative care with health professionals and the general population? I guess that is, people are a bit ambivalent. I don't know, you probably have a better feel for that, you know, frightened of death. What is it? Yeah,
I think New Zealand has become, not just New Zealand, a lot of our Western societies have become death-denying cultures. It wasn't that long ago, 70, 80 years ago, before the advent of surgical techniques, antibiotic therapy, people were dying much more than they do these days. With the advances of medicine, surgery have meant that people are now living much longer lives with very serious illnesses. You know, 50 years ago, if you had a myocardial infarct, you were likely to receive terminal care or end-of-life care straight away because there weren't so many options, but we have become used to people staying alive for much longer. Even cancer, some cancers have become almost like a chronic illness because they can be controlled for much longer. And so people are not used to having conversations. I remember we had a musical therapy student doing a secondment at our hospice. She was 32 years old. She'd never been to a funeral in her whole life. And I think COVID has certainly brought that to the fore, that people are seeing death and dying, all, not necessarily all around us, but all around the world. So it's given the whole world a bit of a wake-up call. And palliative care, part of it is people just don't know what it is. Part of it is the undergraduate curriculums of medical schools, nursing schools, pharmacy schools, you name it. There's probably 1 or 2 lectures over the course of a 4 to 6 year curriculum. But as Bruce and I and all the other doctors in the audience know, that as soon as you graduate, you're doing palliative care on those hospital wards, regardless of how well you've been taught it or otherwise. And so there's a great need for people to learn more about palliative care, and because what you don't know about can be quite scary, and some of these conversations can feel quite difficult. But if you've had a couple of them under your belt with guidance through the palliative pathway activation process through Poi, or through the significant illness conversation guides through the HQSC work, these tough conversations can be made easier for yourself and also for your patients and their whānau. So yeah, something, you know, the more you practice it, the I wouldn't say the easier it gets, the less hard it gets.
I discovered the joy of palliative care when I was working in Vancouver many years ago in a family practice training unit, and our registrars would go and do a month of palliative care, and it was their favorite run. They all loved it. And I guess it was, they got over that fear of death and dying. And so they realized actually there's a lot you can do for people. You know, a good death is something to aspire to, really, isn't it?
That's right, because our focus is not on quantity of life or fixing or curing people, but it is really focused on quality of life, which can be just as important, if not more. And so we may not be able to change the final outcome, but we can make it calmer, we can make it smoother, we can make it less traumatic. And that's what keeps us going. Those of us who work in palliative care, sure, we deal with some really sad cases. For example, last week I was looking after a 32-year-old lady who was dying of her advanced cancer. She was in our inpatient unit and things were not looking so good for her. We were just gently preparing her for that. And all of a sudden she hurt her hip, ended up having a pathological fracture. And so I was faced with a situation of a young lady, 36-year-old, who was dying, but she had an acute hip fracture. She didn't want to go to hospital, so we had to deal with the fracture where we were with pain relief and other things. But just because someone is dying doesn't mean that even more severe things can happen. So it's just about what we could do for the lady, because we got her calmed down, we got her comfortable, which made it so that her whānau could also be comfortable. They were keen to sing waiata with her. It was a Maori family that they wanted to sing with her. This is what they used to do in the good old days. But no one had a guitar. They were all coming from out of town, but luckily we had been donated a guitar from one of our patients, former patients, some years ago. And so that guitar was quickly tuned and brought into play. But the only songs that the person who could play the guitar knew, everyone didn't know the lyrics to, so we quickly printed off the lyrics, and so that everybody could have guitar accompanied singing of waiata together. And our nurse noticed that the patient did seem calmer when this was happening, and then she slipped away quite quietly. And it was quite a beautiful scene. So these are the sort of things that keep us going, really. Sure, we deal with lots of traumatic things, but sometimes you have some just sheer moments of beauty. And
that sounds beautiful. Sounds beautiful. Julia's clarified her question. Oh, yeah. My question is really about relating palliative care to non-malignant disease.
Oh, yes.
I guess is the purpose of having this talk tonight. Your thoughts on that?
Yeah, I think the message needs to get out there that palliative care is not just about cancer care. Certainly that's how it began. That's how the hospice movement began, trying to find treatments to calm down the really terrible symptoms that cancer patients had. But we are now trying to expand into other territory, non-malignant conditions. Dementia is going to be a huge source of palliative care need. Currently, palliative care services, we probably see about 75% of patients are still oncology patients, but at the moment, chronic illnesses are making up 25%. And one of the key things is identification of the patient. So things like the SPICT tool can be really, really useful, but I think it's not just the GPs who need the education, it's actually the hospital specialists. And so now the SPICT tool is going into hospital wards, hospital outpatient clinics. The example that I'll give you of when I was finishing my palliative care training, this is about 10 years ago, I was palliative care fellow at one of the local hospitals, and I happened upon one of my previous MedReg colleagues who was finishing off his respiratory training. He was about 6 months out before he became a respiratory physician, and he knew that I was palliative care fellow on his respiratory ward, and he said to me, "Oh, James, what are you doing on my ward? I don't have any palliative care patients," which slightly flummoxed me, because most of his 75% of his ward was COPD patients, no cure for that. Then there was lung cancer patients, cystic fibrosis patients, interstitial lung disease patients, but he thought that he had no palliative care patients, and I was a bit worried about that. So there's a lot that needs to be done, not just in primary care education or general education, but specialist education as well. So we've got to get the palliative care approach to SPICT tools, the AKPS and phase of illness into hospital settings. And
I remember a statistic from many years ago. I think 50% of people who are admitted to an acute medical unit are dead within 6 months or something. So a large that figure may be way out, but you know your observation is clear.
Yes.
So a question here on medicinal cannabis in such patients to alleviate symptoms, and can there be funding that can be accessed for patients? That's the tricky one, isn't it, with medicinal cannabis?
Sure. Currently, no funding available for the products that can be prescribed. We can legally prescribe things such as CBD oil, so that's cannabidiol. And there's also Sativex, which is the preparation which has a combination of CBD plus THC, which is the psychoactive compound. And palliative care uses of these medications would be mainly in the realm of pain control, but we would have tried the tried and true things such as opioids, anti-neuropathic pain agents such as pregabalin or gabapentin or triptyline. We would be using the things of which have got much more evidence backing. And it's been a lot of people very keen on medicinal cannabis and cannabis-derived medications. But from my experience, we've had some experience over the last few years. Unfortunately, it hasn't been as effective as people would like it to be. So I think in some cases it does work really, really well, but those cases are quite limited, and we would always try all the usual tried and tested, fully subsidized medications in the first instance before trying, so it would be a third or fourth line agent. And the cost is a huge factor, especially in the South Auckland community where I practice. Well, even if I was to require this medication, it would be quite a cost. So we're talking like at least $125 for 25 mils of the 25 micrograms, 25 milligrams per mil dilution, or we're talking much greater prices for the stronger things. A lot of people are very keen on it, but unfortunately I haven't seen huge amounts of benefit. Let's just say I admit lots of patients who are in their pain crises, who are on the cannabis-derived products, and they're still coming in really bad pain. May have some help with anxiety, may be helpful with some appetite stimulation, but the cost factor is a really huge barrier to access to a lot of folks, and I can't see that changing much in the near future.
No.
Lots of studies have gone on overseas in Australia and North America, and start with people who are quite hopeful, but they haven't provided as good benefit for as good bang for the buck as we would have hoped. And the pain specialists have also said that. So we've been quite disappointed, actually. There's not that many tools in our toolbox in terms of pain relief agents and nausea relief agents, and we were really hoping that this would become something that would be really helpful, but in my mind it's been fairly disappointing. But people are still wanting to go for it, and the legally prescribable stuff is quite expensive, so people do source it through non-legal means as well, as green fairies and that sort of thing, but generally hasn't been a great help.
No, I was involved with Graham Gilbranson. We did an audit on his patients, and it wasn't that useful for people with sort of cancer pain. It seemed to work. It wasn't a controlled audit. It was tended to work for the subjective symptoms of anxiety and depression. So still waiting for the trials. I'm surprised there haven't been more trials come out. They must be coming out fairly soon. And the cost issue is interesting because I have connections in Canada, and the recreational users are still using the black market stuff because it's so much cheaper than the legal stuff. But the price of high quality cannabis is that it's expensive.
Yes.
So I've got a question here from Marie. Do you see the potential other health professionals referring into POI, e.g. pharmacists who see patients very regularly and often notice the changes?
Short answer is yes, definitely. And I'll explain that within Auckland, there's 5 different Poi teams. So these are based at local hospices. So there's one at Totara, there's one at Hospice West Auckland, Mercy Hospice, there's Harbour Hospice, North Shore and Hibiscus have a Poi team, and there's a Poi team in Franklin Hospice as well. So there's a regional-wide approach, so we call it the regional recipe. So this is the PPA, the palliative pathway activation approach, but each of the local Poi teams can add its own local flavour to this regional recipe. So some of the Poi teams have got pharmacists as members. Totara's Poi team, for example, we've got pharmacists, counsellors, spiritual care inputs, cultural supports, physiotherapists, nurses, doctors, and so you can sort of have a bespoke approach to the situation. So pharmacists and other healthcare practitioners I could see in the future could have a increasingly bigger role to play. Currently, people who can do a PPA, a palliative pathway conversation and activation, GPs or registered nurses or nurse practitioners. So that's where we've started, but potentially in the future, it could branch out to many more specialities and people.
And we've got a message here from Vicky, who says she's from Waipuna. You would know her. End-of-life conversations and goals of care conversations obviously take time and can be daunting. Have you any thoughts about how we encourage health professionals to seek out these conversations with their patients?
I think these conversations, as I said before, can be daunting if it's the first time you've done it, or but with communication skills training, the dauntingness can decrease. So as part of my own specialist training, we had a communication skills course, and I'm very happy to see that med schools throughout the country are increasing the amounts of communication skills within their curricula, and also experiential role-playing situations which people may cringe at, but they actually can be really, really useful. So I'd say communication skills training is really good. Some of the serious illness conversation guides like the HQSC publish can be really helpful. They can give you a good guideline or a good framework to operate from. That's what the PPA conversation is. It does set out what are the things that you want to cover, and the basics are that it covers all the aspects of Te Whara Tapa Whā. So tinana, physical, hinanaro, emotional, wairua, spiritual, whānau, social health aspects. What's important to you at this stage of your life? What do you really need to do? And of course, this would push people towards possibly filling out an ACP form, which also has more of that conversation. So there is information out there to guide these conversations these days. And of course, if you're having any issues, please feel free to call your local hospice for advice. This is the sort of thing that we do all the time, and we're very, very glad to give helpful advice, or else come along to the local hospice, just see us doing it in action. We're very happy to have people come and visit us, and there's a lot of doctors who aren't in palliative care, may not have actually been to a hospice inpatient unit before. This includes a lot of the oncologists who send lots of referrals to us, but a lot of them may not have had much contact with palliative care during their own training. So something that we've been thinking of doing at our hospice is having an open day, just inviting local healthcare practitioners over, because a lot of folks have an idea of what a hospice looks like, and a lot of the general public has an idea of what a hospice looks like, and that can be quite a scary idea. If the unknown is pretty scary, so please feel free to just, you've got my email address, so you can organise visits to Totara Hospice, but I'm sure the other hospices throughout the country would be very, very keen to get to know you, and very keen to expand our palliative care team, especially our primary palliative care team. So
well, it's interesting. We have a very good training of our medical students at Auckland. Fiona Moore does difficult conversations, and I've had an interesting experience of having spent a few months as an inpatient a few years ago, and I watched our graduates not using good communication in hospital. Closed questions. You haven't got abdominal pain, have you? No, it just hurts over here. And I thought they get it knocked out of them in the hospital. Closed questions are the conversation of our hospital system, unfortunately, in spite of the beautiful teaching they get as undergraduates. they lose
Yes,
it, and that
yes.
and then have to learn it again if they go into primary care. So I think what you're saying is absolutely true. A question here, I think, what is the role of GP in DNAR discussion? Is that a misspelling? Do not
attempt resuscitation. Yeah, I think the GP can have a very important role, because they may well be the healthcare practitioner that knows the patient and their family and their whole illness journey the best out of anyone. So if you've got that long-term relationship, you may well be the most appropriate person to have that conversation, because otherwise it's people in a hospital ward, you go in acutely unwell and they're having this conversation about, oh, we don't think you want to, or we don't think it would be a good idea for you to be resuscitated. It's hell of a scary for anyone.
Yes.
Oh,
yeah.
I'm coming in, I'm possibly dying of something, and now you're telling me that you're not going to try to save me. But the conversation can be planned out gently. If, for example, you notice, oh, the person's going in and out of hospital a few times this year, they've had COPD for years, they've had heart failure for years, they've only usually go to hospital once a year, but now it's been 3 times. Okay, the SPICT would say, okay, is this the time to have that conversation, which could include the do not attempt resuscitation conversation. I really have to have the conversation in the hospice setting, but some people do want full resuscitation, even in the hospital, despite them having their advanced end stage life illness. They want the full works, and you sort of explain to them, well, what you get in real life isn't what you see on the TV shows, like someone dies, requires resuscitation, and they come straight back. They're still able to play the piano, still able to sing their opera songs and everything. But no, we all know that that's not the case. And in our palliative care population, the chances of a successful resuscitation of someone who's got advanced cancer or advanced congestive heart failure or advanced COPD is probably in the realms of about 2%. But as people get more and more functionally unwell, as their performance status decreases, so someone with a AKPS of 30%, for example, they're likely to have a 0% chance of responding to resuscitation. And so it can be a really important conversation to have, that, no, if this happens, this is not what we're going to do to you, because it would, it's a futile treatment in that regard. And we're not in the, first do no harm principles. We do not want to make a bad situation even worse. And so I think, GPs can have a really crucial role, and rather than leaving it to the junior doctor who is admitting the patient in the hospital setting during their really, really severe acute illness, maybe having that conversation some months before that could lessen that blow. And I think it would be a nicer thing to do, and it would provide comfort.
Absolutely. Do you have a preference of tools? Do you prefer the SPICT tool or do you use them in different sort of settings?
I quite like the SPICT tool, because I like the SPICT tool. It's a one page. Comes from University of Edinburgh, so there's lots of organisations using it around the world. I think it is quite specific. It does tell you what you need to do, and so with the Poi PPA programs and everything, we're using it as the trigger. So okay, if the person qualifies, fulfills these criteria on the SPICT tool, they are palliative care patients. Let's treat them as palliative care patients, and let's prepare them for possibly the end of the next 6-12 months. If we're wrong, it's not a bad thing. They've just got some bonus time, so that's currently my favourite. There's other tools, of course, but prognostication. Even I've been working full-time in palliative care for 13 years, and I think I know how to prognosticate, but let's just say I get it wrong all the time as well. The individuals. Some people just have amazing inner strength that physiology can't explain.
I send out a 2-weekly gem. I don't know if you see them. I might send one out with a SPICT tool and get you perhaps to write it. It's got to be in 140 words, so I think that would that would be pretty useful for the sector. So we have about 26,000 people on our mail base.
Oh, great! That'd be fantastic.
Yeah. Okay, so the Waikato Hospice, Debbie and Julia have provides PC support and education. We use all the tools recommended in documents, and we are happy to support Waikato GPs and aged care nurses with their residents in ARC who need a palliative care approach.
Yeah,
the residents do not need to be under hospice for us to help them. So thank you, Debbie. That's very generous of you.
Yeah, no, that's great, Debbie. And I think all of our brothers and sister hospices throughout the country will be very keen to do the same thing, because it's all about, okay, our role is not just to be the inpatient unit or the community team, but we need to train everyone out to be part of our wider palliative care teams. And so, yeah, good stuff, Waikato, but let's do it all over the country.
Yep. Yeah. Okay. Anonymous attendee, excellent case study. It certainly highlighted the impact of communication on both patient and wider family, and the impact on bereavement. Interestingly, there was a follow-on in that one, wasn't there? Thank you for a great talk. Any response to that?
Oh, you're very welcome. And as you said, this case, it did affect me. The look on the husband's face, he was a nice guy, very, very eloquently spoken, but you could see that he was heartbroken. This was 2 months after the fact, and he just felt lost. They hadn't been given a good enough indication of where they were at. And as I said, if they had known, they would have made different choices. They would have seen more of the grandchild, the son. They would have spent maybe a nicer time together rather than that one day in the hospital. And so I did make a promise that I would share this case just for this sort of thing. And the chap appeared at one of our remembrance services a few months down the line, and I had used this case to try and start off another palliative care program. And I did say to them that no, as I had promised, I was going to use this case to educate other people so that it wouldn't happen to them what had happened to them. So he was quite thankful for that, and I think it did bring him a little bit of closure. They had gone through a really bad thing, but sharing their story, the pain that they had felt, was going to help other people. And she was a healthcare practitioner herself. She was one of our colleagues. That's what she would have wanted as well, was what he told me. So that's a good thing.
I'm the complaints officer in our clinic. We don't get a lot of complaints, but when there is a complaint, usually the patients want it distributed to the practice, again, to make sure it doesn't happen again. So we always acknowledge their concerns and say we'll discuss it at a peer review meeting, and then get back to them and say it was discussed at peer review, and they're usually pretty happy with that. So I appreciate you doing that. Somebody's asking for a short workshop or course that GPs can access. So James, I'm going to invite you to the symposium next year, and you can run a workshop on difficult conversations in palliative care, perhaps. Sure.
Yeah,
we're going to be free range. We'll be free range humans next year, not online. And maybe a final question here from Kate. Do you recommend the Amber Care pathway in the hospital setting? Not sure what that is. Could you explain Amber Care, what that means?
Amber Care pathway, I think I haven't had much direct experience. I haven't worked directly in the hospital. I do a little bit of coverage at Middlemore, but Amber Care pathway is something that is to identify the patient at risk of possibly dying very, very soon. So it's to highlight to people that these people may need a more intensive approach, not necessarily an intensive care approach, but a more intensive approach as they may well be approaching the end of life. And thus, you really do need to have a sensible look at what is the right thing to do in their case. Is it still appropriate to have full resuscitation, to have cardiac arrest calls, to have code red calls, that sort of thing? And it is also preparing the patient and the family that things are not looking so good. Possibly you may not make it through this illness, and death may well be coming. So it's a sort of very at the end of the. If think of the big picture with Wally on it, it's more towards the very, very end of that picture. So it's, in my mind, it's quite abrupt. as in, oh, someone's really, really unwell and they might die within the next couple of days. So it's not as gentle an approach as could be done with, say, the Poi PPA approach. Okay, 6 months, you've got 6 months to get your head around the fact that you are possibly dying. That's more time to sort stuff out. But I think the ambient care pathway, it's fine. It's certainly got its use in the acute hospital setting, but it doesn't give people much time benefit. Oh, you've got 3 days to sort this out, and no, that's really stressful. So I think it certainly is a welcome addition to the acute hospital setting, but it's not the be all and end all for anything. I think a longer approach, 6 months is ideal. Sometimes you don't always get 6 months, but having the conversation is the important thing, getting people ready for these transition points. That's what the AKPS and the phase of illness, they can highlight. A transition is about to happen. You have gone from functioning pretty well to functioning not as well, to possibly deteriorating, to possibly dying. And these are transition points which require a transition in our healthcare response as well. Okay, if my patient possibly may be dying the next 3 weeks, maybe it's not the time to send them off for that invasive procedure that had been considered, or a whole bunch of blood tests may or may not be the right thing to do. Seeing them going off for chemotherapy with an AKPS of 20% is probably going to be disastrous. Their performance status is so low. What's their phase of illness? If someone is deteriorating or dying, giving them chemotherapy, radiotherapy, or any invasive therapy might just be the final physiological insult that pushes them off the edge. And so it's what I want to encourage is big picture thinking. We're on this spectrum. Is my patient, where is Wally on the big picture? Is he to the left of the picture, or is he to the right of the picture? And AKPS and phase of illness, as I said, I color coded them to match Wally's clothing as well, so just to trigger that. And what we've done with AKPS and phase and SPICT is we've introduced it throughout the wider Auckland region, because we want to develop a common language, so that if you're in a GP practice, or you're in a residential care facility, or you're in a hospital setting, you can say in one sentence, oh, my patient with a AKPS of 20%, phase of illness is deteriorating. That can tell you a lot in just those 2 small sentences. And then, okay, maybe we're not going to go for full CPR, or this patient isn't going to go for surgery, or to have their invasive whatever ogram.
Yeah.
So common language could be really useful. So that's what we're trying to, that's what other hospices are trying to do across the country as well.
Okay, well, I can definitely feel a gem coming on here, James. So,
sure.
So we've come to the end of our time. I'd just like to thank you. I think that's been a fabulous presentation, and the feedback and the questions has been very, very good. So a big thumbs up to you, and thank you for taking the time to put the presentation together, and thank you for your commitment to primary care training. Lovely to meet you.
Lovely to meet you, Bruce, and we'll do it in person at some stage. Come over to Cafe Araha, just down the road from your practice, and I'll shout you a coffee. And
well, I often come up to the gardens for a coffee, so I'll see you up there sometime.
The food's pretty good as well. We can have lunch, but warm welcome, and extend a warm welcome to anyone else as well. Please, if you've got any other questions,
you'll have some takers.
Please email me. What I didn't mention is that there are GP with special interest internships that are part of the Poi program as well. So if you've got GP registrars who are keen on 6 months, one of the ladies who's working with Bruce at the moment in his practice, she's also working with me in my hospice as a Poi Gypsy intern. So that's a 12-month part-time or 6-month full-time program, and you get intense palliative care immersion. You get to work in the inpatient unit and the community team. You work towards the clinical diploma in palliative medicine, get lots of good skills, and then you get back into your GP practice and export it over there. So little secret agents in the community. We've produced about 10 so far through the Poi program, and we hopefully can keep on doing it.
That's one Mike M did, wasn't it, I think?
That's right,
in
Mike.
our clinic,
Mike also did it.
He's very valuable in our clinic, so that's
indeed. And
okay.
Cool.
Lovely, James. So look forward to meeting you in real life.
Yeah, all the best, everybody. Thank you for your interest in palliative care, and keep on fighting a good fight. You all take care.